We have some incoming questions for the panel. The first one is, can PD-L1 inhibitors be used in immune-compromised individuals, such as patients with AIDS and cutaneous squamous cell carcinoma?
I'm not sure if I heard what you said. Can PD-1 inhibitors be used in patients with AIDS? Right? Yeah. Immune-compromised patients. I'm not aware of any trials specifically for AIDS patients. I'm also not aware of any AIDS patients who were included in any of the trials that led to FDA approval. So no, I do have one. I have a grant to study the effect of PD-1 inhibitors in Ethiopia in patients with locally advanced conjunctival squamous cell carcinoma, and they are heavily HIV positive, but I don't have any data yet.
One question is, my understanding is that you cannot use it in someone with a solid organ transplant, which unfortunately is some of our worst squamous cell carcinoma patients. Is that correct?
That's right. That's a very good point. So organ transplant patients, they would reject their organ by using these drugs. So it's a very tough situation still for those patients. No, we're not using this. It's a contraindication in organ transplant patients.
The next question is, how can vismodegib be used as a neoadjuvant if resistant rest of cells cannot be seen by the pathologist?
How can vismodegib be used
as a neoadjuvant if resistant rest of cells cannot be seen by the pathologist?
It's very hard to actually understand but it can be used as a neoadjuvant if you end up with the shrinking of the tumor and then you surgically remove it. That's the definition of a neoadjuvant. It seems that any residual cancer remains on the periphery, but the deep margin seems to be truly cleared. And beyond that, what we do, and we haven't defined a clear protocol yet, but we take, it's Mohs surgery, so they evaluate the margins by frozen section H&E. Then we take a little more, and then after everything is done, we reevaluate the margins using keratin staining. That's what we're doing right now experimentally. What the ultimate protocol would be, we don't know yet. This is off-label. This is not yet indicated for wide use. So you need to understand any time that you use it as a neoadjuvant, you need to explain to the patient that this is an off-label utilization. It is, in a sense, experimental, and you need to be a little bit more conservative with your margins, take a little more than what you should, but otherwise, but you're trying to preserve the visual function. And by the way, if we ever needed an advertisement against a single pair, I bet you that if the Queen of England had a medial canthal orbital basal cell carcinoma, she would get vismodegib and not an orbital exenteration.
This next question is to Dr. Roos. You mentioned treating the biome for TED patients. Are there specific recommendations you give to patients in regard to this?
So we have, for the last, I think, 15 or even 20 years in Cambridge, what we do is any patient with thyroid eye disease, they get a nasal staph culture. So we culture, see what's growing, and then we treat with mupirocin, Bactrim, and with flucloxacillin for an extended period of time, which the patients do at home, to decolonize the sinuses, because one of the reasons the biome is thought to play an important role in the pathogenesis and helping to stimulate inflammation. This is one of the explanations, or purported explanations, for why the inferior rectus is the most frequently involved muscle, because it sits next to this very large maxillary sinus.
And so by an extended period of time, do you mean 30 days, 60 days, 90 days?
No, it goes on for weeks.
So weeks of amoxicillin? I didn't hear you say.
No, flucloxacillin.
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 Okay, I'm just not familiar with that. Penicillin.
All right. Thank you very much to our speakers, but most importantly, thank you to you all for coming in and supporting the meeting. Have a great evening.